Hi, welcome to Unscrubbed with Dr. Mangs. Unscrubbed is a podcast where I speak to various experts and patients who have gone through their journeys about issues dealing with women's health with a core focus on endometriosis. I'm Dr. Abhishek Mangeshikar. I'm an endometriosis surgeon based out of Mumbai, India, and I lead a multidisciplinary team dealing with endometriosis care. A very integral part of my team is pelvic floor physiotherapy. So I'd like to welcome Dr. Snigdha Mehta, who is a world-renowned physiotherapist, and our focus is going to be on physiotherapy for pelvic floor disorders. Why don't you start by introducing yourself for those of us who don't know you, and tell us about your background and experience in the field of physiotherapy and pertaining to women's health.
Before I start, I want to compliment you on the great work that you are doing and making women's life easier in a problem like endometriosis, because of which they suffer a lot. So great compliments to you, and it's been wonderful working with you since about 2.5 years. So thank you so much for inviting me today. I started my journey in women's health in physiotherapy in 1990.
Okay.
33 years ago. I started mainly with obstetrics, the pregnant women and the postpartum women. Initially, there was no knowledge that they could exercise. They were afraid to exercise, but slowly they started coming in, and then it was a domino effect. They were very happy, they felt empowered, they felt more calm, relaxed, and their labors were easier. And so that has been a long journey. In 2019, I attended courses offered by American Physical Therapy Association, and I got certifications in incontinence, pelvic pain, bowel dysfunction, and I think in 2019 we connected, and we have had a great bond ever since. Yeah, so this has been my journey in pelvic physiotherapy and in women's health.
Wonderful. So I think the pelvic floor in itself is a very enigmatic space. So even gynecologists, or in what we were taught in medicine, it is a very complex structure. There are many levels of the pelvic floor, and to understand those dysfunctions, it's an evolving art and science, and of course multidisciplinary approaches are the way to go forward with these things. And what we've learned earlier on is that, and working with you has been wonderful as an adjuvant, not only in the post-operative care for our patients, but even pre-operatively, leading up to surgery, to identify triggers in the pelvic floor, to identify certain other problems, which we're going to talk about down the line. I think that working together in different aspects of medicine really gives us a holistic approach to treatment of the endometriosis patients and those with chronic pain. So I want to ask you, how does physiotherapy complement the quality of life for patients with chronic pain and endometriosis in particular?
So physiotherapy is, when we show them exercises, they are like painkillers. So when we treat these patients, some of them pre-surgery, some of them post-surgery, the whole body is affected. It's not only the implants that are affecting the woman. The whole body, the myofascial system, the fascia, the connective tissues are all affected, and that is why when we show them exercises, general exercises helps them to release positive chemicals in the body. Endorphins, they help them to, they are mood boosters, they feel much better, and specific exercises help them to relieve the specific pain that they are suffering from.
Focusing more on endometriosis, what are the common symptoms that you experience with endometriosis patients coming to you?
Pain is a big thing, and pain not only in the areas where they have the implants, but pain in the rest of the body. For example, the pelvis is not an island by itself. It's connected to every part of the body. So they may get neck pain, they may get shoulder pain, they may get leg pain, hip pain. So they do suffer from a lot of pains. When they are in pain, their posture changes. They tend to contract that whole part. So they actually, and they also don't move much, and actually that makes the situation worse. So when we open up those areas with exercises, with some of our manual techniques, they start feeling much better, and yeah, that's what it is.
Yeah, even I agree with the same principle, and I'm learning from you as well. Then mobility is one of the things. One of the things I use to explain to patients why they need therapy at the end or even before the procedures is that if this area has been in chronic pain, if you imagine someone with a broken rib, they're sitting and protecting it, and that area is tight for the whole time.
Right.
So the same problem happens with the pelvic floor. There's a tightness and there's guarding of the area, which is kind of a reflex to protect themselves from pain. And then with working with a therapist is going to help open up those areas and kind of work better for the long-term overall healing.
Right. Their breathing also gets affected.
Yes.
They're doing shallow arrhythmic breathing. So the moment we improve their breathing, make it more slow and more rhythmic, they start feeling much better. The movements of the diaphragm are also restricted. So we do some diaphragmatic releases, and that helps them further.
Yeah. It's very interesting that you brought that up, because we were talking about that earlier, and we were saying we all know that the diaphragm is the layer that separates the chest from the abdomen, but many people don't know that there is also a pelvic diaphragm, which is also very important in the breathing process.
Right.
Would you just want to go briefly into that and how that works?
So either it's the pain of the implants that is causing a pelvic floor tightening, or it's the resultant effect of that generalized pelvic pain. So what they do is they hold their diaphragm, pelvic diaphragm or the pelvic floor tight most of the time. And then they start getting pain in that area. They have problems with intercourse. And we help them to release these areas by breathing techniques to combine breathing and pelvic floor relaxation. We show them use of dilators and manual techniques to release the pelvic floor also we do, and that helps them to feel much better.
Coming back to integrative medicine, and a lot of patients ask me, so doc, why do I need physiotherapy? Can I just do a bunch of Kegels and that's it? And I say it's far more than that. So you would really need to speak to Dr. Mehta to understand the intricacies of this. And so can you just summarize why patients need physiotherapy?
So Kegel is a very well-known word, but unfortunately misused. So when Arnold Kegel started the pelvic floor exercises, it was a great boon for all those women who suffered from incontinence. But now pelvic floor is much more complex than that, and we need to specifically examine the pelvic floor and find out what exactly is the status of the pelvic floor, and then show them specific exercises for their pelvic floor with the breathing incorporated. Like I tell them to, while they're breathing out, to relax the pelvic floor, when they're breathing in, to tighten the pelvic floor. So if the focus is on relaxation of the pelvic floor, I would tell them to do a long breathe out to relax that pelvic floor. And often if the pelvic floor is tight, they keep doing Kegels and make things worse, because they don't understand that what is the status of the pelvic floor. We need to relax it or we need to tighten it. Even incontinence could be because of a relaxed pelvic floor or a weak pelvic floor, or even a tight pelvic floor. So it's not only about pain. Pain is one factor, but incontinence is the other factor which these women suffer from, and they don't realize that a tight pelvic floor can also cause incontinence, because a tight pelvic floor is not a strong pelvic floor.
Yes, that's a very important point. I think you elucidated that very well, that a tight pelvic floor is not necessarily a strong pelvic floor. And also one of the things you mentioned that I want to bring into an endometriosis conversation is incontinence is not just a weakness of the pelvic floor. It can also be from endometriosis, which is when there are lesions that are overstimulating the pelvic splanchnic nerves and the inferior hypogastric plexus. And you also see a lot of correlated syndromes to do with painful bladder syndrome. So those are big red flags that you are missing in endometriosis diagnosis if you're only focusing on the incontinence part of it.
Right, absolutely right, yes.
So I wanted to talk to you about manual therapies that are used in physiotherapy that can help patients with chronic pain.
Yes, so exercise is a big component of our treatment, but we use many other manual therapy techniques like soft tissue mobilization. Like I said earlier, these tissues are tight. So when we mobilize those tissues manually, we start with the superficial tissues and then go deeper as the patient tolerates that, and they feel much better. Then we have the trigger point release techniques where we identify a particular spot which is tight, and we sort of pressurize that part very gently, and slowly we feel that the fascia starts releasing. Or trigger point release could be incorporated with the movement of the part. For example, if it is near the neck area, then we tell them to do certain movements of the head, and we release that trigger point. We also release trigger point in the pelvic area, in the other parts of the body with dry needling techniques. So these are techniques that are very useful too. Then we have the visceral mobilization. There's a lot of adhesions inside. So visceral mobilization also helps them get rid of the pain that they're suffering from.
So just to elaborate a little more on those, from what my understanding is, and of course I'd like you to share some details on those, that the dry needling is going to create nerve stimulation on a superficial level.
Yes.
But also the visceral mobilization is like an abdominal massage.
Yes.
That is supposed to help in mobilizing the adhesions.
Yes.
Yes.
Yeah.
Yes.
In the viscera.
Right. Yes.
In the organs inside the
organ
abdomen.
systems.
Yeah.
Mm-hmm. Okay. So could you share some specific physiotherapy exercises targeted towards patients of endometriosis post-surgery as well as pre-surgery, leading up to the time they can get surgery?
So one of the big components, as I said earlier, post-surgery would be, I would start with, after the evaluation that we do, I would start with slow breathing exercises. It stimulates your parasympathetic system, calms you down. Whether it's pre-surgery, post-surgery, both the things, it helps a lot in calming down the person, in making them feel much better, because pain is a perception. Pain could be perceived as really bad or not really so bad. So the perception of pain decreases, plus a lot of positive chemicals get released when they're doing that slow breathing. So slow breathing is what I would normally start with most patients, even if they are pre-surgery or post-surgery. Then I find out which areas are the painful areas. Post-surgery also, in spite of the implants now not being there, they still get pain. And this pain is not directly because of the implants, because of the resultant effect of the implants. It's the myofascial system that has now got triggered, and there's pain there. So suppose they have a lower abdominal pain, I would show them exercises to stretch out that part, to release that part, with initially gentle exercises and then with more vigorous exercises, and in different planes, because the fascia are in different planes. It's like, it's not in just one sagittal plane or a coronal plane. So different angles of exercises makes them feel much better. I also use some yoga techniques sometimes to make them feel better. And when they do that, they say, yeah, we're feeling better.
So just from a technical standpoint, how soon after surgery should one be able to initiate pelvic floor physio? And are there any restrictions on particular subsets of patients, say those who have undergone a hysterectomy and there are sutures in the vagina, or those who have undergone a bowel resection where there's a staple line that you have to be cautious of?
Yeah, so we have to be careful. Yeah, so breathing exercises we can do from day one. We can do gentle diaphragmatic breathing so that the abdomen, actually the abdomen, when it doesn't move, that gives them more pain. When it moves in that gentle manner, as you breathe, it makes them feel better. We may not start with the pelvic floor if those kind of surgeries have been done. We may start with, say, ankle movements. We may start with gentle knee movements. We may start with shoulder movements. We may start with neck movements. And because everything in the body is interconnected, when we start with these movements, they actually feel more relaxed in that pelvic area. So initially we don't start with that, and then over a few weeks, about maybe 6 weeks, depending on the healing time and depending on a particular surgery, in conjunction with people like you who do the surgery, we become a little more aggressive and we start working on the pelvic area too and the pelvic floor area.
Right. I think that's a very good message to take from there, that you should work with understanding what was done and kind of tailor the approach to
Absolutely.
each particular patient individually.
Yeah, right.
Now, coming off a little bit of the surgical conversation, in your own practice, when you are approached by a patient with pain, not necessarily endometriosis because they don't have the diagnosis yet, or even if they were having a prior diagnosis of endometriosis, what challenges do you find that they face in their daily lives, and what are the good options for them to kind of help overcome these challenges?
So most of these patients with pelvic pain, and the diagnosis, as you said, has not been confirmed as yet. What they do is they react to the pain. So they tighten up, they go into that fetal position, they don't want to move, and they are depressed. So talking is a very important part. Listening to them and talking to them is a very important part of physiotherapy. And once we understand them a little better, we create a rapport with them, then we start moving them. And so suppose they are in the fetal position, we may start at the most distal point, the neck, the shoulder, the ankle, the knee, start moving those areas, and slowly they feel better. All these exercises are actually like painkillers. They really make them feel better. The quality of life improves. And we tell them not to be stagnant and not to be static, but to move. So walking, gentle walking, listening to things that they love to listen to, music, so to divert their mind, and a lot of empathy from us makes a big difference to how they feel.
I agree completely. I share the same principle. That's one of the first lines in my presentations is, how do you make a diagnosis of endometriosis? Listen to the patient. You can understand pelvic pain. They're telling you a story. It's your job to connect the dots. I think a lot of that kind of carries over to everybody who's treating these patients. And I want to segue a little bit from the endometriosis patient and talk about two things. One is sexual dysfunction, vaginismus in particular, and then the second would be for pregnancies. So talking about those patients who have difficulty having intercourse, who have pain on insertion or on deep penetration, how would you approach a case like that?
So again, these are the patients who are very anxious, depressed, and there's a lot of pressure on them because they've been probably married and they are not able to conceive, and nobody knows why they're not able to conceive. Everything seems to be okay, but they're not able to have the intercourse, and therefore they're not conceiving. So I talk to them, I listen to them, and then I help them and tell them that there's no pathology. If there's no endometriosis, it's just a tight pelvic floor and just a vaginismus without a pathology. I convince them that there's no pathology. So it's the only problem is that your pelvic floor tightens, and you have to learn to relax it. So I incorporate breathing. So when I teach them breathing and relaxation techniques of the pelvic floor, they are sometimes not able to do it on day one, but slowly they are able to do it. And then once they are little settled, then I may evaluate the pelvic floor from external evaluation, and then I may do an internal evaluation and release those levator ani and those coccygeus muscles. Sometimes they have what we call coccydynia, severe tailbone pain. So we have techniques to release the tailbone from the anal side or from the vaginal side. Right up to the coccyx we can reach, and we can release those coccygeus muscles which are on the two sides of the tailbone. And there are taping techniques which we do for many of these patients. So we can tape the coccyx from outside, or we use also the taping techniques for the pelvic area, the abdominal muscles, to release those muscles.
Oh, that's a very interesting approach. And for pregnancies, what is your kind of regimen for the antenatal patients when they see you?
Antenatal patients are sometimes afraid to do exercises
Yes.
because they have a fear something will happen if I exercise. So I have to sort of tell them, you are absolutely fine, you are a normal healthy girl, nothing will happen to you unless there's a medical reason not to do exercise. They all are supposed to do. So we start stretching out. Like yesterday we had a girl who hasn't done any exercises because of certain problems during the early part of her pregnancy. But now she's already 23 weeks. She had earlier low placenta, now her placenta is fine. So I just made her do stretches, simple stretches. Stretches of the calf, stretches of the thigh muscles, stretches of the pectoral muscles, and she felt so good. She felt so good, and immediately positive chemicals start getting released into the bloodstream, and they are very willing to do the other exercises. Some of them are afraid to do any abdominal exercises. So definitely crunches and leg lifts are a total no-no. They are actually an exercise that should be banned, but they are not, but very frequently seen. They are the wrong exercises. But we start working on the transversus abdominis, the deepest muscle of the abdomen, which I explained to them is like your corset that you wear, and it will help you, and it's the closest and the deepest muscle. So if you have something fragile, I would pack the inner part first and not the outer part. So don't go in for those six-pack looks. Work on your transversus. So, because the transversus abdominis, the deepest muscle of the abdomen, is expanding when you become pregnant. So when we work on that muscle, then they also feel much better. They feel more empowered. Some of them may have round ligament pain. So, and they're afraid. Every time I stand up, I get pain. So I explain them and ask them a lot of questions, and then try to find out, okay, this could be because of the round ligament pain. So I tell them nothing to worry. So I'll just show you some simple stretches, and that will make you feel better. So anything around the abdominal area, they're afraid, because they feel that, am I getting contractions?
Yes.
So I explain to them what contractions are. I also later show them when they are 30 weeks plus, I show them techniques to make their labor easier. I ask the partner to come, and they both do together breathing and techniques, positions, exercises that will help her have an easier labor.
Yeah, that's fair. That's fascinating. So we use the same principle. So we use when we finish surgery, we do a block of local anesthesia into the transversus abdominis muscle.
Okay.
Because we don't want them to be straining their abdomen
Right.
At the end of surgery. So it really brings down pain scores. Of course,
Right.
it's temporary for
Yeah.
48 hours, but that's usually the most painful
Right,
period after
right,
surgery.
right.
So we find that it helps. So it's very interesting that you brought that up,
Yeah.
that is the foundation of the core per se.
Yes, yes.
Let's talk about mental health. And of course, we know that chronic pain patients have been, probably gaslit for a good majority of their lives. We know that the average endometriosis patient takes 7 to 10 years to get a diagnosis and has seen at least 5 doctors before they receive a diagnosis, and they are told to get married and have babies, and once they get pregnant, all their problems will go away. So this obviously is going to take a toll on them, that they feel that they're not normal because they're feeling such heightened sensations of pain when everybody else around them seems to be breezing through their menstrual cycles. So what aspect does mental health and mental well-being play in your practice when you see these patients?
Usually physiotherapists see them much more often than obstetricians
Yes.
or gynecologists. And we sort of create that little connect more easily, because they don't feel in awe of us. So when we talk to them, and there are so many little things that they are not answered by the busy obstetricians often. So we are the in-between connection where they can ask us questions, and so that itself sort of makes them feel much better. Plus, when you take them in a group, a group of pregnant women, they are a great support system for each other, and they feel, okay, I'm not the only one who's having these problems. There are others who are also having the problems, and that bond is so strong that, and I've been doing this for years, as I said, 33 years. And what is happening is that they are like family to me, and they all create such a great bond that they become lifelong friends. Even their spouses become lifelong friends, and they no longer have that fear that, things that are, emotionally they feel very confident and very empowered.
That's wonderful. And thank you for sharing. We don't get the opportunity to have a group, and so I think support groups are very important for pelvic pain as well as mental health,
Yes,
and that
yeah.
is wonderful that you're able to offer that to your patients. And I want to thank you for taking time out. I know your son is visiting today, and you took precious time out to come and spend some time with us. And I learned a lot, and I'm sure everybody who's watching did as well. So thank you for that.
Thank you so much for having me today, and thank you so much for the wonderful work that you're doing on behalf of all the women of the world.
Thank you. If you enjoyed today's podcast and want to see similar content like this, don't forget to like and subscribe, and follow my other social media handles, which are posted down below, and also Dr. Snigdha Mehta's Instagram handle listed in the information below.